Thank you, Dr. Marks, for the opportunity to present here. I practice in Temple, Texas, at Bell Scott & White Central Texas campus. This is my disclosure. For those who are not familiar with ICG, indocyanine green is a fluorescent dye which is used as an indicator substance. It's water soluble with a molecular weight of 744. It can be injected into bloodstream with no adverse effects. Becomes fluorescent upon excitation by laser beam or light with wavelength in near infrared spectrum, approximately around 820 nanometers. When it's given IV, it rapidly binds to albumin, and it shows up near instantaneously in the vasculature and the target organ. It is contraindicated with iodine allergy. The total dose should be less than 2 milligrams per kilo, and it's reconstituted in sterile water, 2.5 milligrams per ml. This table shows it's seen within the bloodstream between 5 and 30 seconds, and then in the target organs such as kidney, liver, adrenal glands, and small bowel, it will be visualized in between 1 and 2 minutes. It lasts around 20 to 30 seconds in the bloodstream and 20 to 120 minutes in the target organ. It is detected by specialized scopes and cameras. There are various systems out in the market. Intuitive has Firefly. There's SPY technology used by plastic surgeons for open reconstructive surgery. And Stryker has their 1588 and 1688 cameras. It has been used for decades in ophthalmology and for retinal angiography, and it has also been used for hepatic blood flow function. Has been used for hepatic blood flow and function, cerebral blood flow by neurosurgeons, and biliary topography. There are various applications in surgical fields, especially surgical oncology. In breast cancer, it's used for sentinel lymph node drainage. In gynecological surgery, for endometrial and vulvar cancers, for sentinel lymph node drainage and pelvic sidewall lymph node dissection. For urological surgery, it's used for periprostatic tissue identification as well as pelvic sidewall lymph node dissection for advanced prostatic cancers. It has also used in liver metastatic disease. It is preferentially taken up by the metastatic tumor in the liver. And for skin, it's been used for sentinel lymph node drainage. ICG used in colorectal also has various applications. I personally use it for anastomotic perfusion and urethral identification, particularly in redo pelvic cases or complicated diverticulitis cases. It's given into the stents prior to operating, and it will last in the stents for over 8 hours. It is also used, the use in lymphatic mapping and tumor localization has been described as well. For lymphadenectomy, it's in surgical oncology, the nodal status is the most important prognostic factor in gastric and colorectal cancer. It is the standard of care for these patients. Several studies have shown use of sentinel lymph node procedure using radio tracers or blue dye or both. With the varying lymphatic drainage patterns, it comes in handy, especially when you're looking at a tumor at splenic flexure or hepatic flexure with watershed areas. It also, and gastric and colorectal cancers also report high areas of skip metastases, that's when ICG green comes in handy. Dr. Gisbert has already touched upon the role of sentinel lymph node dissection for gastric cancer, but it has been around since early 2000s. I'm just going to skip over the ICG for gastric cancer. As you can see, and she's already shown in her amazing videos, the use of IC green for fluorescent imaging with infrared electronic endoscopy. So, sentinel lymph node in gastric cancer. The importance of sentinel lymph node dissection in colorectal cancer is unclear. Lymphatic mapping is beneficial if assisted by intraoperative fluorescence. Method of administration is for intraoperatively. It can be injected laparoscopically or robotically subserosely with a catheter placed through a port. And submucosally, it is injected preoperatively prior to the start of the case. I personally use it for tumor identification or marking my distal margin. If it's a low rectal cancer, I would inject 3 cc's prior to, 1 cc's prior to start. So I don't have to do confirm with endoscopy if my tumor margin is adequate. As I mentioned, it's 1 cc given. Mean time is 4.3 minutes to achieve lymphatic visualization. The reason sentinel lymph node dissection for colon cancer is controversial because the sentinel lymph node detection rate is between 65 to 100%. There are small case series which have shown detection rate as high as 88%. It is highly accurate. It has higher accuracy in early stage tumors. Only one study showed no false negative cases in T1 and T2 cancers. However, with the T3 and above, they had 46% false negative rates. A higher T stage impedes lymphatic drainage, leading to higher false negative rates. This is a in vivo sentinel lymph node identification using fluorescent track imaging in colon cancer. It's a systemic review and meta-analysis, which shows, again, the detection rate for the early T1 to T2 cancers is 90%. For both T1 and T2 and T3 and T4, the detection rate is 90%, but the accuracy goes down to 77% for T3 and T4 cancers, and the sensitivity drops from 80 to 30%. There are further 2 meta-analyses evaluating ICG detection of sentinel lymph node in colorectal. They were, in 74% of times, it was true positive, and 26% time false positive. And the sensitivity, again, ranged from 0 to 100% for these cases. There was another meta-analysis which was performed looking at the studies between 2006 and 2016, and the upstaging rate of 12.3% for METs identified in sentinel lymph node dissection. When a pooled analysis of over 1,100 metastatic lymph nodes was performed, the sensitivity was 71%, and the specificity was around 84%. Accuracy, again, was up to 75%. So 25%, it's not quite accurate. So sentinel lymph node dissection for colon cancer, currently no support for widespread use of ICG. There is a small study of 21 patients which showed fluorescent nodes when given when the ICG is given preoperatively endoscopically does have proximal to IMA ligation, can alter the management of the patient, and it is modifying the lymphadenectomy in 23% of the patient. Another potential application for IC green is for mesocolic excision for right-sided colon cancer, particularly when the lymphatic drainage is unclear for hepatic flexure or transverse colon cancers. Now, sentinel lymph node mapping in low rectal cancer. This is a study from Japan which looked at the sentinel lymph node use, ICG green use in sentinel lymph node dissection for rectal cancers. Low rectal cancer has 2 major lymphatic flows, IMA and the lateral ligament to internal iliac artery. Incidence of lateral lymph node mets for cancer below the peritoneal reflection is around 20%. And after the lateral pelvic lymph node dissection, risk of pelvic recurrence will decrease by 50%. And 5-year survival improves by 9%. However, it comes at a cost of urinary and sexual dysfunction by disrupting the autonomic nervous system in the hypogastric plexus area. T3 and T4 tumors are indications for lymph node pelvic dissection, but controversial due to the low accuracy of pre-op workups such as MRI. For the use for rectal cancer, the radioisotope is injected endoscopically. For T1 cancers, it was used submucosally, and for T2 and above, it was injected into muscular propria. And this, the Japanese group performed prophylactic lymphadenectomy in all patients. This is a video, actually, one of my colleagues at Temple, Texas, he's a gynecological oncologist who routinely performs pelvic sidewall dissection for endometrial cancer. The concept is the same for rectal cancer as well. This is a video by Dr. Chad McCormick. He gives IC green 1 cc in the cervix prior to starting the surgery, and once once he's done the hysterectomy, now he's proceeding to do a pelvic side wall dissection. You just saw the iliac artery onto the left, and the lymph node, the pelvic side wall lymph node highlighting with the icy green. It's hard to see. Okay. This table highlights the distribution of the lymph nodes it associates the lymph nodes with the T stage, and you can see the higher the T stage, less likely they're positive. So 70% of the time, it was the lymph nodes were positive for T1, T2 cancers only. I'm going to skip over that. So performing sentinel lymph node navigation surgery in lower rectal cancer may avoid lateral pelvic lymph node dissection. Side of pelvic lymph node dissection is based on tumor site, right versus left versus anterior or posterior, and may lead to avoidance of local recurrence after surgery. So in conclusion, ICG-guided surgery has potential to improve quality and diagnostic ability of oncological surgery. However, it's not widely used for colorectal. It can be used for intraoperative support for surgical strategy and decision making, and the future directions of new technology with ICG application. Thank you.